Welcome to the RSNA RadioGraphics podcast. My name is Jennifer Weaver, and I am a musculoskeletal radiologist at Vanderbilt University Medical Center. Today, we have a special guest, Dr. Angel Gomez, a musculoskeletal radiologist from the University of Texas at San Antonio. Welcome, Dr. Gomez.
Hello, Jenny. Thank you so much for inviting me here today.
Today's podcast focuses on something we see commonly at level 1 trauma centers, calcaneal fractures. These fractures can certainly be complicated and intimidating. Dr. Gomez is a co-author on the RadioGraphics article, Multi-Detector CT Evaluation of Calcaneal Fractures from 2011. This article is part of the RadioGraphics On-Call Preparation Article Index. Dr. Gomez, can you give us an oversight of this article and how you see it useful in practice?
Yes, of course, certainly. As we all know, trauma is very common. And the calcaneus is the largest tarsal bone and is responsible for supporting the axial load of all our body weight. It is commonly fractured after a fall from height and can also be injured in motor vehicle accidents. Although radiographs are usually the initial imaging study for calcaneal injuries, most patients undergo CT evaluation for further characterization of these fractures. CT evaluation, a 3D approach as opposed to the 2D approach of radiographs, allows for better visualization and characterization of the fracture planes and the fracture displacement. This permits more reliable fracture classification, and a better classification, improves the treatment outcomes. I feel that this article is a useful review for both musculoskeletal and emergency radiologists. Additionally, I think this article is a good reference for radiology residents and fellows. This article describes the normal CT anatomy of the calcaneus, discusses the Sanders classification system for intra-articular calcaneal fractures, and reviews the complications that can occur with calcaneal fractures.
As radiologists, we know that understanding anatomy is so critical. Can you tell us some of the important anatomic considerations that you think about when you approach the calcaneus?
Yes, of course. The calcaneus has 4 articular facets, one of which articulates anteriorly with the cuboid, and 3, which are the anterior, middle, and posterior facets, articulate superiorly with the talus. The sustentaculum tali is an eminence of the medial aspect of the calcaneus that supports the middle articular facet and under which the flexor hallucis longus tendon passes. The peroneus longus tendon courses along the lateral aspect of the calcaneus in a groove under the trochlear process. Fractures associated with these areas may cause tendon injury or entrapment. The calcaneal body is mainly cancellous bone with a very thin cortex. The bone under the posterior subtalar facet has higher density cortical bone to better support the axial loads along the angle of Gissane. If you look at a lateral ankle radiograph, the angle of Gissane would be that V-shaped cortical density created by the superior calcaneal surface. In calcaneal fractures, an angle of Gissane greater than 130 degrees indicates depression of the posterior facet. The angle of Böhler is another important angle formed by the intersection of a line from the highest point of the posterior calcaneal tuberosity to the highest point of the posterior facet, and a line from the same posterior facet point to the highest point of the anterior process of the calcaneus. An angle of Böhler less than 20 degrees indicates posterior facet collapse from an underlying calcaneal fracture.
We know calcaneal fractures commonly occur due to increased axial load from falling from a height or through motor vehicle accidents when the feet are pressed against the car floor. The force drives the talus into the angle of Gissane, causing the posterior facet of the calcaneus to rotate forward and generate a primary fracture plane. Greater forces can lead to secondary fracture planes, usually exiting the upper or posterior calcaneal surface. Additional or different fracture patterns can occur with even greater forces. How should we initially evaluate these images?
Well, initial assessment of suspected calcaneal fractures typically involves radiographs. The recommended views include the axial, which is the Harris view, the anteroposterior or AP, the oblique views of the foot, the lateral view with specific foot movements to visualize the different joints and the facets. Earlier classification system for calcaneal fractures relied on radiographic findings, with the Essex-Lopresti system being a well-known classification system. However, conventional radiographs have limitations in visualizing all the calcaneal anatomy.
In most institutions, CT examination is usually the next step in evaluating calcaneal fractures after radiographs. CT allows us better visualization of the subtalar joint. Multiplanar reformations allows us more accurate evaluation of fracture planes, fracture dislocation, and fracture comminution. As you know, fractures are categorized into intra-articular and extra-articular based on the involvement of the posterior facet of the subtalar joint. Can you discuss a little bit of the differences between intra and extra-articular calcaneal fractures?
Yeah, of course, that's actually very important. Intra-articular fractures of the calcaneus account for approximately 75% of all the calcaneal fractures in the adults. The Sanders classification system is commonly used to classify these fractures based on the location of the fracture lines at the posterior facet. The classification system correlates with management and prognosis with moderate inter-observer variability. Type 1 fractures are non-displaced, while type 2 to 4 are displaced fractures with increasing numbers of fractures, lines, and fragments. Type 2 fractures consist of two articular pieces from a single intra-articular fracture line and are further subdivided based on the location of the fracture line. If it's lateral, it will be a 2A, central a 2B, and medial a 2C. Type 3 fractures consist of three articular pieces from two fracture lines and have different subtypes. Fractures with more than three intra-articular fracture lines are classified as type 4 and are considered comminuted. Extra-articular fractures make up approximately 25% of the calcaneal fractures, and they do not involve the posterior facet or the subtalar joint. These fractures are divided into three categories based on the location of the calcaneal involvement: anterior, which will be type A, middle involvement, which will be type B, or posterior involvement, which will be type C. Type A fractures involve the anterior process. Type B fractures involve the mid-calcaneus or the body of the calcaneus, including the trochlear process, sustentaculum tali, and the lateral process. And type C fractures involve the posterior calcaneus, including the posterior tuberosity and the medial tubercle.
Thank you, Dr. Gomez. That's a great summary of how we classify calcaneal fractures. When we think about how orthopedic surgeons approach these fractures, there are several different treatment methods. Non-surgical treatment is usually reserved for non-displaced or minimally displaced closed fractures, as well as extra-articular fractures. Surgical intervention is recommended for displaced intra-articular and open fractures within the first 3 weeks after the injury, and involves open reduction with internal fixation and possible arthrodesis if the fracture is highly comminuted. Timing of surgical intervention is determined based on the stage of fracture healing and reduction of swelling.
Yeah, unfortunately, complications after calcaneal fractures can occur, and they're often associated with the fracture itself. Early detection of skin and soft tissue compromise is important to prevent complications such as wound infection. Up to 20% of patients, especially those with open fractures, may experience wound complications and infections, including necrotizing fasciitis. Tendon injuries can occur when fibers become entrapped between fracture fragments, which can be identified on CT. Tendon entrapment can also hinder fracture reduction.
Thank you, Dr. Gomez, so much for being my guest for this episode of the RadioGraphics podcast. I hope everyone listening can feel a little more confident in their evaluation of calcaneal fractures. Please take the time to review the excellent images online in this article.